This next panel that we're going to have for you today, Heart to Heart, Breaking Down Barriers to Clinical Research, we have Dr. Elizabeth Ofili and Sheila Thorne. I was getting ready to go in for a small procedure, and they wanted to check how strong my heart was. And they asked, do you know how your parents passed? My father. So I was able to tell them that my father passed from congestive heart failure. And so they said, we needed to know that, because now we know what to look for. We need to know if your heart is going to be strong enough for the procedure. And it was. Well, look who's joined us, ladies and gentlemen. We're going to introduce these ladies to you today. These are the members for our next panel, Heart to Heart, Breaking Down Barriers to Clinical Research. And I was just giving them another one of my few stories that I shared.
I was normal, getting up, excited to go to work every day, running after the kids down the hallway, running after my kids. I mean, it was normal, excited, healthy, enthusiastic. And then all of a sudden, like, I started going to work and I just started slowing down. It's like, I started walking and it's like I'm walking with my feet asleep. Like my feet were going to sleep. I was told I had high levels of lipoprotein little a, and that would put me at risk of having a heart attack or a stroke.
Cardiovascular disease still remains the #1 killer. African Americans are more likely to die from heart disease and stroke. Roughly 30% higher risk of dying from heart disease. Lipoprotein little a is one of the risk factors for atherosclerotic cardiovascular disease, which is, plaque buildup in the arteries that would eventually lead to a stroke or a heart attack. With lipoprotein little a, we're still trying to understand what those elevations mean, especially for African American patients.
So the African American Heart Study is a unique cardiovascular study. We're actually doing it in collaboration with Morehouse School of Medicine, as well as the Association of Black Cardiologists. And what we're trying to do here is measure what's known as Lp(a), which is lipoprotein A, levels in African Americans across the US.
What's really unique about this study is, in addition to getting a really detailed understanding of the clinical progress of those patients and their disease, we take all sorts of information from their blood. Then we try to understand what's the relationship between those biomarkers, those proteins, and the progression of disease.
We really want to see proportional representation for participants in our trials. How are we going to do this? There are barriers to clinical trial participation in certain populations, things related to systemic issues, mistrust of medicine. There's also barriers related to geography, there's barriers related to finances, and we want to help change that. And we'll do that with partnering externally with the community. The RISE work that we do, the representation and clinical research work that we do, is very important to advance this, to advance the conversation, and to ensure that we are making a difference to all patients.
I am really excited for my patients as well as for myself as a cardiologist, because now, with this study, we are going to engage and enroll patients who can get new knowledge about their disease or what they are at risk for. We are looking forward, because we're getting all of this new information, to understanding how it's affecting us as Black people. Because right now we don't know that. And knowing that is truly power.
Good afternoon. It is a pleasure and an honor to be here at Black Health Summit, and I'm distinctly excited about being with this physician sitting to my right, Dr. Elizabeth Ofili. I tell her all the time, I'm the captain of her fan club. We've worked together for a very long time. We're not going to say how many years. No, okay. But suffice it to say that if you want to talk about heart disease, we have the right person here to talk about a specific kind of heart disease, because its indication with Lp(a), very highly unknown. How many of you know about Lp(a)? Raise your hand. Wow, a few people. Well, after this session, you're going to know a lot more. Clearly, cardiovascular disease is the #1 killer in the US and internationally. So we have an international expert here to talk about this. But it's a unique collaborative partnership that makes me very excited because it's going to take all of us, each one of us, to make a difference for all of us. So this is an area that is particularly important. The Association of Black Cardiologists has always been at the cutting edge of research with regards to heart disease. In fact, Dr. Ofili was the first female president of the Association of Black Cardiologists. Give it up. Well, I'm here just to lead the conversation. I hail from New York City, born in the boogie down Bronx. So the Bronx is in the house. But in any event, this is a serious topic. And this study is particularly important and groundbreaking and landmark. And I really want Dr. Ofili to help us understand why this partnership of Morehouse School of Medicine, the Association of Black Cardiologists, and Amgen Pharmaceuticals. What a combination. How did this all come about?
Thank you.
I think it's on. Yeah?
All right.
Okay, good.
Thank you so much, Sheila. That was outstanding, as always. Always a pleasure to be on stage with you. I really appreciate it. And thank you, Black Health Matters. I think that clearly you've packed the house in here, and we're excited to be a part of this. So I just want to say, in terms of how this all started, we really have to give credit to Amgen. And you heard the person on that in that video is a leader at Amgen. She leads an area called representation in clinical research, set up specifically at Amgen to address this across the entire company. And who is her primary person who came to me? He's in the crowd. Can you guys just give it up for Jude Gang? Yes. So Jude and the entire team, they're wearing their Amgen shirts, and I definitely appreciate that. You can really know a company's priorities based on what they structure as a strategic priority, and that's what happened when Jude came to me and said, well, you know, we are interested in understanding better the lipoprotein(a), how it affects blacks, and he's not telling me something I don't know, because as a cardiologist, for years, we knew about the dangers of lipoprotein(a).
Yes.
But the problem is, as soon as you hear about it, then the next thing that comes out of everybody's mouth is, but we don't really know what to do about it. We know that it affects, as the patient you were hearing from was saying, leading to heart attacks in younger people. So there's almost some opportunity here to understand how. Then the other piece of it is blacks are more likely to be affected.
Yes.
And in a serious way. And I can just tell you guys, this is just as an anecdote, so you can go check your Lp(a) after this session. My daughter, who's in the audience, was at a cardiology meeting, and she got her levels checked, because people are talking about it now. And she told me it was elevated. I said, well, what do you mean? You know, she goes, it's elevated. She says, Mom, do you know your level? So I'm a cardiologist, and I pride myself in knowing everything. I know my LDL, I know all these others, but I did not know my Lp(a). She goes, well, you better check it. I said, okay, I will. So finally, I did get it checked, and it's exactly the same number as hers.
Wow.
Why do I give you this historic context? It's because we know now that Lp(a) is stable from when you're about 5 years old. It's a genetically determined risk factor. And then we don't really know how to get it down. Whatever that level is that you were born with stays with you. Drugs that are currently treating bad cholesterol don't work for it. Lifestyle, I exercise, I do everything, that doesn't work for it. But fortunately, and I know we'll get to that, so let me just answer your final question. So I'm going from story to story to story. And Sheila is sitting here, I need to take that mic from her because she is not answering my question. But I really said all of that to say,
yes,
there needed to be a whole engagement around it, and Amgen did it the right way. They came to me and said, we know you do research.
Yes.
We would like you to be the global PI for this, and we would like to involve a lot of organizations that you think matter.
Yes.
So they came to ask that question. And of course, being that I am a cardiologist and a professor at Morehouse School of Medicine and Morehouse Healthcare, we thought, well, we can definitely start with that because they know the community. Of course, the Association of Black Cardiologists.
Yes.
At the end of the day, we wanted to get to these practitioners, the physicians themselves, who are across the country, but they're seeing more African American patients. But guess what, guys? They don't get invited to do these studies.
That's right.
They do not get invited.
That's right.
So
Yes.
Amgen said, we want to make sure we're looking at these community-facing physicians who see the majority of patients.
Makes
like
sense.
us.
It makes
So
sense.
that's how it started.
Fantastic. Well, obviously, your collective wisdom is going to lead us in the right direction.
Yes.
But talk to me a little bit about clinical research. We know that Blacks historically have been reluctant
Yeah.
and resistant to volunteer for
Yeah.
clinical research for good reason.
Yes.
History, unfortunately, has
Yeah.
not been a friend to the community.
Yeah.
So why is this study different?
Yes. Very important and very, very good question from all of us that are sitting here and trying to say, well, I'm hearing about LP-little-a, or maybe
Right.
I hadn't heard about it, but what does it mean? What else can we learn? So the premise of the study is we, at the very least, need to understand how it's affecting Blacks,
Uh-huh.
right? So the design is for this observational study.
Observational, okay.
And what is observational? What that means is there are no drugs involved, but we are going to get information and connect it to everything else we know. Because there's data on LP-little, but a lot of it is on people of European ancestry,
Right.
not in people of African descent.
Uh-huh.
So then that's why this study is specifically designed for people of African descent to get information. And I'll tell you exactly how the study is structured, and then
Please.
we can come back to that
Yes.
later as people have questions. First of all, as you saw in the video, I don't know if you noticed, there is a website. It is called www.aaheartstudy.com.
There you go.
When you go to that website, there's important information that's easy to digest. I know I have my person there going, go on, get on with it so I can get the information. When you go to aaheartstudy.com, it'll tell you about the African American Heart Study, who can join it. That's the first thing you should always ask when somebody's trying to tell you about a study. Am I eligible to participate, and what do I need to do to join? So in this particular study, we're looking at people who are 18 years of age and up to 85.
Uh-huh,
So
okay.
it's a pretty broad.
Very
and we're
broad.
Starting from 18 because people, when you have LP-little-a, it can lead to a heart attack at a relatively young age. In your 30s, your 40s, like the patient you saw, that's the kind of thing we want to cover. So that age group, you can be a man or a woman
Okay,
to be a part of it. We have it as what is called a case control. What does that mean?
Okay.
That means people who have had an event, if you've had a heart attack, if you've had a stroke,
okay.
or if you haven't had those events, but your doctor told you you have blockages in your heart arteries or blockages in your leg arteries, those are also criteria to come into the study.
come into the
as
study.
a case.
Gotcha.
And then for a control, we actually have to have you matched to a case that's already in the study. So controls have a little bit more of a journey to get in, but you don't really have to have had these events to be in. You can still participate if, we're matching based on the gender and the age. You can be matched if you're between three years of plus or minus of somebody who's a case. So when you go to that website, you'll see how a very simple questionnaire, you can go down and see how you potentially can join. And if you meet a criteria to be a case or a control, we would basically move you into a process that gets you to our team members who are working with the study, and they will in turn, we have like 35 sites around the country.
I was going to ask you about that. 35.
Here in Atlanta, we have about 5 doctors who are in different practices. I know some of you know Dr. Michael Toka. They're all cardiologists. They're here in Midtown Atlanta, in DeKalb County or Decatur, in Noonan, in Macon too.
Okay,
So we've
okay.
got those doctors, the site. So you will have a choice about where you could be directed.
Convenience of location
Yes,
makes a big
yes,
difference, doesn't
right,
it?
right.
Okay, okay.
Now, guess what? We want, yes, thank you. I knew you would ask me that. Thank you. Even if you think you don't qualify, just go to the website because you get a lot of information on why this matters. And then we put you into our pipeline of email so we can share information with you because there are studies going on now. Drug studies, that's not what we're doing, but
Right.
the drug studies eventually should have enough African American patients because we want to know basically if we reduce this level, which the drugs have been found that reduce it by over 95%,
Really?
just with 2 shots, with a
Interesting.
shot every 3 months.
Okay.
When you get that information, check on that because these drug studies that are going on, we want to know maybe after a few years, does it matter how we reduce it or when we reduce it, do people actually live longer? Do they have less heart attacks? So even though our study is not a drug study,
Right.
the information that we're
The
collecting
data. Yeah.
will absolutely support what happens down the
It'll
road.
change the treatment methodology, won't it?
Absolutely.
Fascinating. Now, how many are you looking for? How many participants?
We are looking for 5,000. We already have close to 2. We now have 1,600. Everybody give us a hand, please. 1,600. And it's not easy doing that. The study itself is not a difficult study because it's just one visit to the doctor's office.
Okay.
And then we'll draw some blood work because we've got to look at the genetics of it. We've got to look at other what we call biomarkers. What are the other things circulating that come along with Lp(a) that may be affecting the rest?
I see.
And then on top of that, we want to make sure when we get this information in that we're able to run an analysis and talk to you about those results.
You sound a little bit excited about this study.
Terribly excited. I'm glad you
But
noticed.
why? Why is this so different? Why is this unique? Why is this groundbreaking?
The reason, simply put, is when a company does a study and goes to the FDA, because everything you're taking now, I don't care, aspirin, any medication that's over the counter, they had to be tested. And now the FDA is saying, you can do all the tests you want, but we want to make sure, does it work in the demographic that you're looking at? So the fact that we're going to get 5,000 African American patients
Amazing.
and understand how the Lp(a) profile looks and what is the genetic underpinning behind that. Can you imagine then when Amgen goes or any other company that's looking at Lp(a) goes to the FDA and goes, hey, we studied this. This is a percentage that participated among African Americans. And guess what? We also know about a whole bunch of people who maybe didn't have an opportunity to be in the study, but this is what their profile looks like. That becomes critical,
Critical.
in terms of addressing the disparity.
But Dr. Ofili, trust, mistrust, distrust has always been a part of the Black community's thinking when it comes to clinical research.
Yep.
How does this study address and acknowledge the lack of trust that we have in the medical community?
I am so glad you asked that. Because everybody sitting here knows when you're in front of your doctor and your doctor gives you a recommendation, whether it's here, take this medication, check your blood pressure, go check your cholesterol. I want you to come back every 6 months or a year to do a check. All of us try to follow that,
Yes.
right? Sometimes life happens and maybe it's a little slippage in that. But what happens is sometimes doctors don't even bother to mention the opportunity to do a clinical trial.
That's often the case. That's right.
Because they already built an assumption that we won't participate.
That's
And yes,
right.
we do have difficulty because of all the historic mistreatment
Yes.
and all the historic deceit around research.
Unfortunately, yes.
What we find, this model, because we're working with these trusted providers.
That's key.
First of all, the Morehouse School of Medicine, they have a community advisory board that looks at how we've designed the trial, how we're engaging folks, and they,
Okay.
some of what you do, Sheila,
Yes,
of course,
yes,
to say, well, maybe this consent form could be simplified a
Yes,
little bit, just so people can read it easily.
Yes,
That's
and
one
understand
thing.
it. Sure.
But I think the most important reason is because we're working with these doctors, the people already know. They trust them because they go to them for care. And the doctors who are part of our studies look like the patients.
Well, there you
for the
go.
most part.
There you go.
And if not the doctor themselves, because we know there's not enough black doctors to take care of all the sick patients with heart disease who are black. So we have some white doctors, but you work with them to
Oh,
make
yes.
sure they're culturally
Competent, culturally relevant, culturally respectful.
exactly.
Yes, yes,
So it
yes.
is that whole cultural congruence
Mm-hmm.
that is involved. And I think that's is why we're
Key.
at 1,600
Absolutely.
participants.
Well,
But we've
congratulations.
also got to acknowledge that people can't just jump in research. You've got to support them.
That's right. You really do.
And that's what we're doing, making sure what is a barrier in their practice.
Uh-huh. It could be money.
Is it a barrier?
It could be
Sometimes it's money.
transportation.
It's transportation.
Uh-huh,
It's
okay.
how will patients get there? How do they, when they get there, get the information to participate in the study? So all of this was looked at, bringing a lab services to draw the blood so the doctor doesn't have to send them somewhere else.
Makes a big difference.
Having the doctor properly compensated so
Mm-hmm.
when they examine the patient and take time off their schedule and their health research coordinators take time to explain they're not rushing.
Uh-huh.
We
Yes,
want to make
yes.
sure that is done right at that level.
Very important, often ignored.
Yeah.
But now you've talked about the sites in Georgia. How about sites elsewhere? We have family members in other
Yeah.
parts of the country.
Right.
Relatives and
Right.
friends. How can we get them to at least consider
Yeah.
looking into a site? Are they scattered throughout the country?
They are, and I'm glad you asked that because we looked, obviously, as you guys know, in the United States, there's a concentration of black people in the Southeast.
Yes.
So we wanted to make sure we fully cover the Southeast. We have sites in North Carolina.
Okay.
We have sites across on the East Coast, several sites in Texas, because Texas is a big state.
Yes.
And then we also have sites in the Midwest.
Good.
Chicago, Michigan,
Okay.
New York, Harlem. I know
There you
you're from
go.
New York.
Right, my old stomping grounds. Yes. Okay.
But on when you get into that website and you express an interest, our team will direct you to a site.
Excellent.
Yeah.
Excellent. So the investigators are diverse.
Yes.
The patient population is diverse.
Right.
The cultural issues have been addressed in advance
Yes,
proactively.
proactively.
And Morehouse obviously leading the charge under your leadership and guidance for a national campaign.
Yes.
It's understandable why you're excited about
At
this.
the ABC.
And the Association of Black Cardiologists.
If you
That's
look
right.
at- We have a, I think we had, hopefully we still have it, but there's like a flyer
Mm-hmm.
that was developed by the Association of Black Cardiologists, just making sure the communication aligns with what we've worked with over the years.
Over the years.
That resonates with black patients. At the end of the day, we're talking about Lp(a). But it is not the Lp(a) molecule that matters here. It is what happens to us when we leave here. I was just called in to see a patient who was having really sky-high
Right
blood
here,
pressure.
right here at the summit.
Right here at the summit.
Okay.
So it is what happens. It's about recognizing these risk factors that could lead in death. And so we want to be able to not only represent in clinical trials, but we want to represent in care. We want to represent in access to that care.
That's critically important. So the partnership has covered all the bases.
Yes.
You've got the Amgen resource, source, and spirit.
Yes.
You've got the Association of Black Cardiologists with the clinical expertise, and one of the premier medical teaching institutions, Morehouse.
Yes.
It's a trifecta.
Oh,
You-
we are
you got
so
all
glad.
three, all
We are
three.
excited.
Yes.
And we definitely thank Amgen's leadership here and everybody who's participating, all of these physicians in their practices, the research coordinators, they are a big part of why research is successful. And of course, I want to acknowledge my team that's been working with it. Shimite Obialo here, and I believe Marcia Watson and Deborah and Tim are somewhere. But we could not do this, obviously, without support and sponsorship.
That's exactly right. Partnerships are the key to success, collaborative relationships.
Yes.
Well, the ABC is celebrating its 50th anniversary
Yes,
this year.
indeed.
It
In
was established in
California.
1974, and I just spoke to Dr. Richard Allen Williams the other day.
Oh, wow, that's
And he's
great.
the founder
Yes,
of
he's
the
the founder,
organization.
uh-huh.
So those are the partners that we really need to have at the table.
Yes, indeed.
This is not easy,
Yes.
but it's doable.
It's doable,
Yes.
but we're doing it. And that's why I'm saying to people, everybody, if you're, as my pastor would say, if you're within the sound of my voice,
There you go. There you go.
Just remember, it's not a one and done deal. Get excited here and then go out and get some information.
Spread the word.
There's plenty of information
Yes.
out there. When you go to that landing page, you'll see a lot of information. But then come back again and again and ask the question, how does this affect me? How
That's
does
right.
this affect my family?
That's right.
What can we do in the meantime? And how do we know when we have some information about drugs that could help us out? Because at that point, I think we would have enough knowledge to know not only the overall effect, but if there's any potential side effect and how we manage it.
Well, talk about the test for LP little a. What
Yes.
does that involve, the test?
Yes.
To find out what your level is.
Yes, so the test for LP little a currently in our study is very carefully standardized, but there's a version of it that you can get in your doctor's office. You know, when you go to get your cholesterol checked, it's called the lipid panel. You ask your doctor, you say, could you please add my LP little a, because it's not a part of the lipid panel.
Uh-huh.
And so when you say LP, again, it's LP and then A. Everybody knows it now, but you got to be able to verbalize it to the doctor.
You have to ask for it.
And they'll check it and they'll give you the number. It could be a little off based on the research we're doing, but at least it gives you something to start with.
Gotcha, gotcha. So the study has begun.
It has
You're
begun.
currently recruiting.
Yes.
You're looking for more participants,
We are.
and
We
and
gotta get that
5,000 is the
5,000.
goal.
Yes.
Okay, very good.
Yes.
Well, why don't we open it to the audience? We've given them a lot of information. I'm sure, whoa, look at the hands that flew up. Let's get some questions.
Questions. Okay, we're gonna. Hold on. Here
It's
you
coming.
go.
We'll get to
We're
you.
gonna get everybody.
We'll get to you.
Trust me, guys, we sat there for 30 minutes waiting for the previous panel, so we know you guys have questions.
There you go.
Okay, I won't be long. I am a patient of Dr. Toka's office. Yes, I am. And I wanted to know whether or not Dr. Harold Lightfoot is a part of this study.
No, he's not, but he can still refer because we've got
Okay.
It's Harold Lightfoot.
Lightfoot,
Is
yeah.
he a cardiologist?
Yes, he and Toka are they were partners.
Okay.
Before he moved to Carolinas. And I do receive the newsletters from the Association of Black
Cardiologists. Awesome.
Yes, a lot of
Awesome.
Excellent.
very informative.
Yes.
Okay, thank you.
Thank you. Thank
Okay.
you so much.
Questions.
Let's go one into the other, giving a workout, aren't we? Yes. Okay.
Good afternoon.
Good afternoon.
I'm Roseanne Merchant, and I just want to thank you for being here and dispensing so much important information. In my family, we have a very large family. We have a lot of people who have had heart conditions. My mom, who died a week shy of her 99th birthday, but she just knew everything, you know. And myself, I have a low ejection fraction. And the question I have is, this is the first time I'm ever hearing of this LP little a.
Yep.
Yes.
What is the normal number for that?
So that is a little bit of a range right now, but it definitely needs to be under 150, the way it's measured.
One
150, and the lower the better.
Yes. Okay. And the doctor can tell you right after you take the test?
Well, you know,
take a while.
generally you have to come back to the
panel,
office
right.
and then they'll give you that number.
Okay.
But I want to be clear now. Remember, there's no treatment right now. So
Correct.
like I'm carrying my number, but you monitor everything.
I
And
see.
You make sure all the other risk factors like your cholesterol and your activity and your
Mm.
blood pressure that they're as low as possible. And then you keep your eye out for these drug studies that we're talking about.
Excellent.
Your ear out, yes.
Yes, ma'am. I may have two questions. You know, a lot of the baby boomers, we're caregivers of our 80-something-year-old parents, and we're stressed out, women trying to carry so much. My cholesterol, I don't know if there's a connection between the high levels of stress and trauma as we get older, and the cholesterol and the blockages of the arteries and all of that start happening. So is there anything natural that we can eat, like my mama says, oatmeal, old-fashioned oatmeal?
Yes.
Besides taking a lot of drugs, because do a lot of drugs have certain long-term side effects?
Yes. So this, you had like 3 or 4 questions, but we'll start.
And I got one main one.
Okay.
If you could, as the heart specialist of America, please find out if we could have more free yoga. We had it over at Spelman in the Art Museum.
Okay.
And that's the only thing, because we can't get out as women anymore on a regular basis. It's too much going on to go out
Yeah.
walking by yourself.
Right.
But the yoga and the meditation, it really helped me not to overeat, eat the wrong things, and the yoga just got all that negative energy
Oh,
out.
that's wonderful.
That's
So
excellent.
free yoga again at the art museums.
The art
and-
museum.
And the libraries,
Okay.
the churches and
Well,
everywhere else.
let's
Thank
take that
you.
back.
Thank you,
Yes,
baby.
thank you so much. Those
Excellent.
were excellent questions. So let me start with, could you put your hand down, sir? Thank you. We'll come to you. Let me start with what you asked about natural ways to manage this. And then also, first of all, go back to how we get these risk factors to start with. So some of them, as we mentioned, like Lp(a) would be genetically driven, and there is also levels of cholesterol that are determined from a genetic standpoint. We know that. Those levels tend to be much higher. But there's also what happens is all of us get older, the cholesterol actually goes up, especially among women. And part of that is related to menopause and the loss of estrogen. So keeping an eye on it on an annual basis helps you see where things are going. Now, there's no question that we have drugs to treat cholesterol, but some people, have concerns with side effects, and that's understandable. Generally, the way we look at this is, what is going to kill you first? And I'm sorry, I'm a cardiologist, so that's where I go. So if the level is so high, and we know that there's a gradation, the higher it is, the more likely you will have a heart attack. Then we would say, okay, let's put you on a treatment. And there are now treatments. Some of them cause side effects, some of them not so much. So it's understanding if the level is high enough to need a drug, don't say, well, I'm just going to do the natural things. There are natural products that help reduce cholesterol. For example, 100% plant-based diet, if you can do it. If you can get rid of meat and eggs and dairy products, the cholesterol level will come down. But
Oil. She said
What
oil.
oil?
Olive oil?
okay, oil like oil. Ah, yes. Oh yeah, I hear you now. Yes, certain types.
Certain types.
No, not all. Like the olive oils of this world. I think that's what you were saying. Yes, the Mediterranean diet.
Right. Yeah.
Fruits and vegetables help. But I'm telling you, if you're dealing with a family-related high cholesterol, it's not going to be enough.
That's right.
So all I say is, do all the natural things. Do your diet modifications. Yes, yoga and stress reduction helps. But keep an eye on it. Keep
Yes.
checking it. Make sure it's going in the right direction. Now, with that caveat, if you already have blockages in the arteries, then that's a big risk. Because the blockages could just be irritated, and we don't know all the reasons why. And then all the blood cells starts packing on it, and that's a heart attack happening. And there are now ways that your doctor can check. I have patients that have really high cholesterol, reluctant to take meds, and I say to them, okay, let's do a scan of the arteries. And it's not, nobody's poking a needle. It's non-invasive. The scan looks to see, do you have plaques?
How much is
If
there?
the plaques are building up,
Yes.
then we are having a different conversation.
Problem.
Does that help some of the questions?
Okay.
Thank you.
Okay, and this is our last question right here.
Oh, don't do that to people.
We're not going to run away.
This woman has had her hand up, and I have to say, from
there
the
are a few over
stage,
there.
we're going to need her to
His
answer
brother as
at
well.
some point.
Yes.
Yes.
Okay.
Yes, good afternoon, ladies. Does this study take into consideration, because I have congestive heart failure and I take a water pill, and being a veteran trying to get health care, trying to see a cardiologist at the VA, medical centers, just like pulling wisdom teeth. It's been very difficult because they schedule their appointments out about 3 or 4 months
Yeah.
at a time. Now, in this study, does that take into consideration the congestive heart failure?
So if you have congestive heart failure, you are not necessarily excluded, but your congestive heart failure has to have been because of a heart attack. Because sometimes there are many reasons people go into congestive heart failure. And so that could still be, you need to go to the website and see if you would be a potential participant, because having a low EF, like you mentioned, does not exclude you, but is the reason why you have the low EF. It has to have been a heart attack. Because we want to make sure we can obviously get the understanding of that original process in terms of the heart attack.
So Dr. O'Feely, I think we said the last question. You're going to have this? Okay.
Yes,
One
please. Yes, please.
Okay, hello.
Hello.
My LDL is 225.
All right. She knows her number.
That's
Love it.
a family issue.
Yeah.
Yes.
And actually, the doctors are wondering why I have not had a stroke or heart attack.
What is your HDL?
HDL is something like 330.
No. That would be the
Oh.
total.
Yeah.
Yes.
It's 89.
Yeah.
Yeah.
Your HDL is high.
Yes, yes. And actually, a lot of people already asked the questions that I had to ask. But I do need a conscientious doctor. You know, on April 16th, I have a cardiologist appointment
All right.
at Piedmont.
Yes.
So,
Great. There are good doctors at Piedmont too.
Okay.
In addition to Morehouse. But there are good doctors at Piedmont. No, I'm serious. I have many good cardiology friends at Piedmont. They do a great job. And in terms of the VA piece that you asked about earlier, sir, the VA, sir, I just wanted to say, you know, Morehouse actually has a satellite VA location. So sometimes with the VA, you can be seen at other locations through your primary care doctor, but it still feeds into the cardiology. So explore those additional options, and I definitely appreciate the question.
Don't give up.
Okay, we actually have one last question over here.
Okay.
I missed her hand. Go ahead.
I'm sorry, I actually have 2 questions. The first one pertains to the clinical study.
Yes.
I heard you mention the payment that's going to the researchers, but what about the participants? I
Great
think it's kind
question.
of good for people to know
Yes.
that when they participate in a clinical study, that there could be some form of compensation
Yes,
given
thank
to
you.
them.
Great question, and I'll take that. I know you have another one. So because we value your time, we do compensate you $125 to be a part of this study. And again, that's acknowledging that your time is valuable.
And with the LP(a), you're looking at the LP(a) mass or LP(a) cholesterol?
So right now, it is measured not with necessarily mass, but it gives you like the milligrams per deciliter, the way all the other the LDL cholesterols get measured. The LP(a) gets measured the same way. In the study, we are exploring, measuring it, you know, a mass to see if you get the same impact depending on the measurement, because I can tell a thing or two about these measurements. So eventually, through the African American Heart Study, we will have both options, because that's part of what we're trying to know about as well.
So, Dr. O'Feely, what message would you want to leave our audience with about clinical research in general?
Yes.
And about the African American Heart Study in particular?
I'm just going to steal that message you said out there, molecules to market, because we don't know if a drug is going to work for us if we've not been a part of the research.
That's right.
And there are safeguards put in, there are questions, you have that informed consent. I just want everybody to not immediately say, I don't want any of that. The question should be, how can I be a part of that? And I have questions, who's going to answer the questions? So have a mindset of curiosity, because this whole disparity has got to end.
Indeed.
We cannot keep saying black people this and black people that, because we
right.
have very good genes.
That's right.
We actually absolutely have very good genes. The problem is when we start getting into the healthcare environment and people start discriminating, people start ignoring us, the only way we get to not be ignored is to come in with questions and have knowledge and therefore insist that the doctor listen because you're paying for that service.
That's exactly right. Nothing about us without us.
That's right.
Okay.
Thank you.
Thank you all so much for your questions. And what's the website again, Dr. Ofili?
aaheartstudy.com. Can you guys say that with me like Oprah? Huh?
Thank you for joining.
sorry,
And
what did
hopefully you'll spread the word about LP
Better than
little
Oprah.
a. Thank you so much. It's right on the screen.
Thank you. aaheartstudy.com.